You like it? Hearts. That's going to be the topic of the day. Pretty excited. Rare opportunity. We have very special guest today, and I guess I should say very close to my heart. If I want to get as cheesy as it gets. He's
it's a little cheesy.
A little cheesy, yeah. Take two. Should we take another one? No, I have our Calgary's own cardiac surgeon, Dr. Bill Kent. Welcome.
Thank you. Pleasure to be here.
Yeah, anytime. Thank you for taking time out of saving lives and shaking hands and kissing babies and doing what you do.
Thank you.
Good. I am excited about this for a lot of reasons. The first being, of course, love you. You saved me, but it's not like I was rushed in there in an emergency situation, but you did. You do what you do by saving hearts. But also I think, from the care and everything and the level of care that I had received, which is why I became kind of passionate about it. But I think it's a good opportunity to share with people, first of all, your journey, but just spreading the word on heart health and then most importantly, the things that you do at the Libin Institute and the things you guys do. So I really appreciate you coming in here.
It's my pleasure.
Awesome. So let's just take it back. So take it back. You grew up in Ontario. I knew that. I mean, we got to know each other a little bit, but did you grow up in Ontario or did you?
I did. I'm a transplanted Albertan.
Yeah, well.
I'm thinking now 11 years in practice. I've been in Alberta for 11 years. No, but I grew up in Ontario. In Sarnia, Ontario. So a small-ish town in Ontario, but around here everybody knows it because it's an oil and gas city. Oil refineries were the major employer in growing up in Sarnia, so I knew about oil and gas as a young guy.
Yeah, for sure. Mm-hmm.
I did most of my training in Ontario before I came out west to Alberta.
Mm-hmm.
I started in University of Western Ontario. Then I did med school at Queen's.
Mm-hmm.
I wasn't directed to cardiac surgery initially, but became interested in it during the course of my general surgery training. And I had a real strong mentor. A lot of us have mentors that really influence the direction of our careers and our lives. And that's what happened to me. Sort of drew me to cardiac surgery.
Is that right, hey?
Yeah. I had a guy who was a great surgeon, taught me a lot about surgery and about life, really. And he was, when I was training in general surgery at Queen's, he sort of said at the end of my training, "Are you going to go into cardiac surgery?" I thought, no, I hadn't even thought of that. But he said, "Well, I don't understand why you've spent so much time working with me and spending time with me throughout the 5 years that you've been here, and you tell me you're not going to do this." And I said, "Well, I was heading in a different direction." And he said, "Well, I know some people. Maybe I trained in Edmonton. Maybe I can see if there's a position open for you." I thought, well, geez, I don't know. I don't know if I'm up for a whole bunch more training. But, he said, "Well, let me just look into it." And he comes back to me the next day and he said, I got your spot. You're going to Edmonton next year. So
no way.
That's how I started at West. I made my way to Calgary, through Chicago for extra training, and then back here to practice in Calgary.
Oh, that's wild. You never know. Well, you mentioned you were going to different. What were your aspirations, or what were you thinking you wanted to be doing?
I liked cancer surgery originally, and so I was interested in head and neck oncology, and I had a fellowship lined up in Toronto, I enjoyed that, but I'm so happy that I ended up in cardiac surgery. I think it's a more rewarding career for me, and it suits it suits the way I am as a person. So,
yeah, perfect.
I'm lucky, but that's the way it goes in life.
Yeah, that is the way it goes in life. You just never know where you're going to end up. And so how long have you? So how long have you been west then? What year would that have been when you moved?
Oh, I'm thinking that was 2010.
Mm-hmm. Yeah, okay.
And so did training in Edmonton, a little bit in Calgary, and then went to Chicago.
Mm.
and came back to work here.
Came back to work, and you've been there ever since.
Mm-hmm.
Well, the Libin Institute, which is, I guess, what you would technically work for right now, right?
Yeah.
Or yeah, how
Alberta
does that
Health
work?
Services. Libin Institute is a cardiac institute that's a lot of it's donor funded, and their pillars are of innovation, of bringing new research focused, training focused, and so they support a lot of programs within Foothills and programs that are otherwise wouldn't be supported to take them forward to the next level,
right,
in cardiovascular sciences.
Mm-hmm. No, it's an incredible facility, and it's pretty amazing how much they'd done. I pulled up one article. I was kind of familiar before, just the Libin family, that because they recently donated another additional funds, $7.5 million back in 2022, up from their initial donation of $15 million, so well over 24 million, which is pretty incredible.
Oh, they've been very supportive.
Yeah, they are supportive. Yeah. I got to meet. I have met Ida, Nora, and Stuart, and coincidentally, I just had my brother-in-law in here.
Oh yeah,
last week. He's just a private venture, private equity guy, but him and Stuart are actually friends.
Oh yeah.
So when you operated on me, and then I will explain some of it. It was pretty wild. I had no idea there was such a family kind of connection already to the Libins, which is interesting. Okay, well, I did want to dive into specifically my surgeries, and then
sure.
Maybe we can talk about commonalities or whatever. We'll see where it goes. But so I had come to you, or I guess it would have been Dr. Matland.
Yes.
Initially. Is he moved on? He was talking about retiring?
Yeah, he's retired. I saw him last week, though. He's enjoying retirement.
Is he?
Heart surgery becomes such a part of your life, obviously, that it's all-encompassing. So sometimes heart surgeons have a hard time stepping away. And you really have to find something else to fill those many, many hours that you're used to being in the operating room. So I wondered about him because he spent a lot of time. He was a hard worker, dedicated. Yeah. But, he said to me, I said, how are you going to handle this stepping away? Like, are you going to be able to do this? And he said, I've reached the point where this job does not define me, and I don't want it to define me for the rest of my time, and I have other things I want to accomplish. So we say that. A lot of people say that, but I think he's doing it. He's very happy. He's
good.
Traveling a lot.
Excellent.
And he's got a lot of other interests.
Mm-hmm. Well, great care for me. I felt like he was excellent, and obviously trusted him. I had to. He would have given me my initial, diagnosis or prognosis. So I had this murmur to explain. First of all, it's a murmur. It was a big murmur, but how common are murmurs? They're super common. I feel like everybody I know has a murmur almost.
Yeah, murmurs very common when you're younger, and murmurs are turbulent blood flow, and you hear that with a stethoscope, and so you can hear blood flow, and you can hear some turbulent flow in a normal heart in a young person. Really easy to hear through a thin chest wall. Becomes less it's not a normal finding, I guess, as you get older.
Right.
When you develop a murmur when you're older, it's usually something. And usually it's a leaky valve or a valve that's too tight. So in your case, you had a leaky valve. Now that in of itself isn't a reason to require surgery, but in your case it does, and it's a sign for some. Yeah,
because when I had come in, I was shocked. I knew I had the murmur, and anytime I would do, because I love surgeries. I live in the surgery room, so one of my old knee surgeries, they kind of picked up on it. You have a murmur, but then anytime I would go and get like assessed for things, they'd say, "Wow, you got this big murmur," but no one really did anything, and until I got tested, and then that's when I got the call and said this is serious. So So you mentioned, so it was a leaky valve, and you guys had suggested yourself or Dr. Matland, and then I think you assisted.
I did.
You assisted. Yeah. Mm-hmm. So there were two options, essentially open heart or the minimally invasive surgery. Mm-hmm. And you guys kind of told me, you can explain maybe the major difference between minimally invasive and then going open heart, the obvious. But
yeah. And so when we think of heart surgery, we think of surgery done through the middle, through the breastbone, and that's by far still the most common way. Mm-hmm. But when you have a valve problem, it's an isolated valve problem, meaning there's nothing else wrong with your heart. Mm-hmm. You can do a more targeted approach. You don't have to do a full sternotomy. There's some morbidity with that. It's tougher to recover from a big incision. Yeah. Minimally invasive option allows you to address the valve by doing a small incision that doesn't go through any bone or doesn't involve the same trauma, I guess. Mm-hmm. And you were a good candidate for that because you're young, and when you're young, you can get back to a productive, active life a little quicker, right? Mm-hmm. So that's what I still believe is the big benefit to minimally invasive surgery.
Yeah, the recovery. And I know you guys had said to me after that my surgery went way longer than probably should have, only because I was just a big guy. Like, we'll try to keep details out of it, but I mean, it was just hard to get into the body, I think, because it was really the issue, right?
Yes.
Yes.
Some people are bigger guys. I mean, you got a lot of muscle. It may be a little harder to expose.
Okay.
See the valve, but
yeah. Okay, so anyway, you guys completed the surgery on me, and then he did say, Dr. Matland had said after that, wasn't able to fully get rid of the murmur. It went from like a giant murmur to slight, and I do remember he had said, we may see you in 10, hopefully not, but we just don't know.
Yeah.
And I'm sure the minimally invasive, I guess it takes away from, you're not actually able to see everything. So maybe, is it?
I think that's one of the advantages. You can see everything. Again, we use cameras and specialized long instruments to be able to see the valve real well. And that is an advantage of the procedure too. But what he was telling you essentially is like sometimes when you fix a valve, it's variable. You can get a perfect result. Sometimes it's a complex thing, understanding valve anatomy. And in your case, at the end of the operation or on your follow-up echocardiogram, there's a little more leak than he liked.
Yeah.
And sometimes there's, if you look at people over the long term, over sort of 20 years, there's a proportion. Probably the most would be somewhere between 10 and 20% of people over maybe a 20-year time span would need something done again.
Right. Okay. Yeah, and I remember you had said to me, I asked the question, which I'm sure almost all the patients do, and I go down the Google rabbit hole. You're talking about what are the odds of survival, and am I going to live? And you were both extremely like. It was under 1%. I'm pretty sure you said it was under 1%. You just both made me feel so at ease. Not that I had any reason to worry, but so it's just it doesn't happen.
Yeah,
it's got to be.
Yeah, it's a big responsibility. Now it's your particular operation wasn't associated with as much risk as some, certainly.
Yeah.
But yeah, and these are the in the early days of valve surgery. We're talking about and which aren't that long ago. Like the heart-lung machine was really developed late 60s.
Yeah.
70s, 80s. It was still early days of, heart, cardiopulmonary bypass and open valve surgery. So we've come so far.
Yeah, very far.
And the risks are so much less than they once were, especially for the type of problem that you had.
Yeah. I'm trying to, I was trying to wrap my head around how the bypass machine actually works. I can't seem to wrap. Can you explain to me how it works?
Yeah. So, I mean, The term heart-lung machine is the best way to think about it, right? So you have, it's got two components. One does the work for the heart, and the other component does the work for the lungs. So there's an oxygenator, and there's a pump, and so that's the components of it. So in order for that to work, you have to take blood out of your body, you put it through the pump, and then through the oxygenator, so the blood gets pumped back into the body after it's oxygenated. And that does the work of your heart and lungs while you're having your heart arrested. So we can work on the inside of the heart.
Yeah. Would there ever be a time you would work on a heart while it's still pumping?
Yeah.
There is?
Sometimes, yeah.
What would...
Yeah, you can work on the heart when it's still beating. The reason why we generally arrest the heart is because then you can evacuate all the blood. So it's a dry field.
It's cleaner.
You can see exactly what you need to see. But sometimes for doing bypasses in the front of the heart or procedures on the right side of the heart, you can keep the heart beating. So that usually means going in the bypass machine, but not clamping the heart and arresting it.
Okay. Yeah, man, this is all just beyond the scope of. People ask me how. And I'm sure every other heart patient, people ask, like, how did you go through it, and how do you wrap your head around it? And there's no simple answer. You have no choice. You just do it. But it really is remarkable what you guys are able to do. How do you feel knowing that, like, your job is to save lives? Does that ever...
Yeah, I mean, I really don't think about that on a daily basis. I mean, yeah, it does weigh on me. I mean, that's part of the responsibility. I think of it as you have this tremendous responsibility for your patients, but with that comes tremendous reward. So when you see your patients do well, it's just, I feel it's a real lucky position to be in. To have somebody like you to trust you is, yes, ton of responsibility. But the positives outweigh the negatives.
Yeah, of course,
right?
Of course. Yeah, I mean, I'm not trying to drudge up anything that's gone wrong, and obviously, you focus on the positive, and you're doing a good thing.
Yeah, and and yes, things do happen, right? You can't save everybody, and when they're real sick. Despite your best efforts sometimes. But those are the minority. Most of the time, it's good stories. And, you accept risk with the patient, and but things work out well, and it isn't so rewarding to have people come back and tell you they feel better.
Yeah, it would be. I can imagine. Okay, so... We'll get through both of the surgeries. I do want to go talk about some other things, but
sure.
I was told, like I said, Matland mentioned, not quite where we want it to be, and then I got the kick in the teeth in 2019, I guess it would have been. You got to come back. It's back and it's bad. And then I spoke to you on this because you were going to be performing, not assisting, and you did say, we have to open you up. And you said, I need to see it. And we also said, you said, I'm getting a new valve. That was the plan. I was to get a new valve, and I would go on blood thinners. So what are the advantages, like, I guess, because there's two types of valves.
Yeah.
Right?
There's tissue valves and mechanical valves. And I'm telling you, your story is a story that's, it's a very real story, because, this isn't the way it's supposed to go. You're supposed to have your operation to fix your valve, and that's the end of story. So, this is like it just demonstrates, medicine's not perfect. We don't, so it's good to talk about it that way too, right?
Okay.
Because, you're in the minority of people that have a valve repair fail, but it sometimes happens, and you gotta deal with it and get the patient through and back to living a very productive life like you are.
Yeah, no question. Yeah, I've got nothing but thanks.
It's a good story.
It's incredible. It worked out.
We did talk about what are the options if we have to replace your valve, because sometimes after it's fixed the first time, and when it starts leaking again, you can't re-repair it. Usually, oftentimes. So you can put in a mechanical valve, and a mechanical valve is made out of carbon. It's a very rigid, durable structure. It's a one-way valve, and the downside to it is you need to be on blood thinners for the rest of your life. I think we talked about that.
We did. From what I got from the conversation was pig valve, tissue valve. I don't know what it is, but is it a pig valve?
Yeah, it's a pig valve. Pig valve and cow valve are two of the options for the mitral position like yours. Usually a pig valve, but there's a cow valve that's very, very durable as well. So
but if you go with that route, you don't have to be on blood thinners, but you tend to put that in older patients because it doesn't last as long.
Doesn't last long. And particularly in somebody who's younger. So it tends to last a little longer in somebody who's older. A younger person tends to wear out quicker. So in your case, we'd be looking at 10 to 15 years. The valve wears out, and then you're requiring third-time surgery.
Got to go back in.
Not ideal.
Definitely not ideal. Yeah, please. don't want to have to go through that again. No, I think we made the right call.
Yeah,
or you made the right call.
Yeah.
So
we made it together.
Yeah. Well, yeah. I guess we had to talk about it.
Yeah.
But so anyway, you got in there. So I go in. When I go in for the surgery, I wrap my head around. Okay, I am getting a mechanical valve and blood thinners for the rest of my life. That was just the deal.
Yeah.
And then you got in there. So what did you see that changed your mind?
Well, I wish I could say I remembered your valve.
That's okay.
Like yesterday.
It's a while ago, and you see a lot of hearts, so I just appreciate you.
You know what? I reread your operative report to remind myself.
Well, sure. Got it,
yeah. No, the thing about it is it's like anything that you fix. You need a good tissue. You need robust tissue. So some people, just the nature of the disease or the way they're born, their valve tissue is weak, don't hold stitches. So ultimately, you're fixing a valve. It's like it's like sewing any other tissue. You got to have good tissue to be able to bring those stitches together and do what you want to achieve. Often you don't have that, particularly on a redo operation. In your case, I thought, you know what, this tissue's healthy. It's good. It's strong. It's going to hold stitches. I'm going to be able to re-repair this. And so I wanted, I always want to do that. Whenever I'm going into a surgery. And that's what I love about valve surgery in particular. It's like art. You got to understand the anatomy of it. You got to see it in 3D. You got to work with the tissues. And really, generally, if you can make it look good, it's going to work well. So, I mean, I saw that potential with your valve. And I thought, and you know what? We can get a good repair with this. So.
Oh, yeah. It's fantastic. And so you put in an annuloplasty ring.
Yeah.
And so what is that?
Yeah.
I have a card with a serial number.
Yeah. Which you don't need, by the way.
Yeah. I don't need it?
Not really.
Okay.
No.
I don't know why they gave it to me.
You could see your ring on a chest x-ray. Because what it is it's a metal ring covered in fabric so I can put stitches through it. So when we do that, we use it to shrink down the size of the valve. So one of the things that can happen with a valve that's leaking is it can increase in size. The backflow from the leaky valve causes an increase in the upper chamber of your heart, which is the left atrium. That enlarged left atrium can make the valve bigger. And so part of the strategies to repair is to put a ring around the valve, bring it down in size.
So it can come down.
Yeah, and it helps it to stay competent.
Yeah, because that was the other thing I kind of skipped over was, my heart was enlarging or enlarged, which is, I guess, common.
That's right.
With the leaky valve.
Exactly. Yeah.
How does it work with the aortic valve on the other side? So it's left atrium, right atrium.
Yeah, same size. Right. So four valves, of course. On the left side, there's the aortic valve and the mitral valve. So your mitral valve was affected, and then also on the left side, the aortic valve. So that left side is what pumps blood to your body. So higher pressure, systemic circulation. So those two valves are more often diseased. So the aortic valve is adjacent to the mitral valve.
And
yours is in good shape, though.
Good. Happy to hear. Do you perform on all all like aortic, any cardiac and blockages? Do you get into? Because I want to touch on that.
It's not my area of expertise. No? Certainly, but all cardiac surgeons do bypass surgery as well. It's still it's the majority. If you look at the overall volume of heart surgery that's done, I believe it's not 70% of it is bypass surgery. Okay, it's the most common disease, so we all do it as heart surgeons, and I certainly do. My area of particular interest is the valves, but certainly I do bypass surgery as well.
Well, it's the number one global killer. It's the last stat I read was something like 17.9 million annually. Yeah. That was from the World Health Organization. It's the number one killer.
It is the number one killer, and that's why it is good to talk about. And, having disease of the arteries that supply blood to your heart, that's that's treating that or preventative strategies to minimize the risk of you developing atherosclerosis, hardening the arteries, or blockages in your arteries. That's what causes death. That's what causes heart attacks. We do know that your arteries are nice and clean because we always look before we do valve surgery, because we want to make sure that the arteries are clear, because if I'm in there going to operate on a valve, I want to make sure I don't need to do bypass surgery at the same time.
And from my understanding, correct me obviously, blockages can either be like it's a hereditary thing, or diet, obesity. It's one of the two.
It often is,
right?
And especially in younger people with healthy lifestyles that end up with coronary disease, they often say to me, like, "What did I do wrong? What did I?" And often it's nothing. Sometimes it's you just inherited the predisposition to develop high cholesterol, maybe, or whatever it is about the makeup of your heart that you develop blockages. So, yes, that's true in a lot of cases. But you mentioned the big risk factors: diabetes, smoking, high cholesterol, high blood pressure. Yeah, these things are big factors.
Yeah, I definitely wanted to go there because I think it's important. For people, I think we need to talk about heart health and the vices or the bad things and the hearts that you're seeing. So I at one time, and I'm sure doctors have different opinions, but I heard Dr. Matland told me he had said 1 red steak a month. I remember he said that to me. One, I see hearts, 1 red, and I just thought, not happening. Are you crazy? What do you recommend in terms of diet and
I'm
eating
not as
and consumption?
Tough as him.
Yeah.
I always say we do these operations a lot for quality of life. So you got to balance it with quality of life, but not to minimize that point, because it's a good one. Your diet does matter, and I think that having a diet that is not balanced or doesn't include a range of all elements is certainly going to have an impact on your overall heart health. So, but I mean, this is something you work with your family doctor, and it's important to have your cholesterol checked, to check your blood pressure, and and that should be treated. Now, that doesn't necessarily mean drugs. If you do have high blood pressure, if you do have high cholesterol, there are other options, and diet-related options can be there. But often it does, and we're predisposed to these things, like we were talking about. If you're predisposed to develop coronary disease, well, often we're predisposed to high blood pressure or to just the way we're made, and so medications are often required as you get older.
Well, speaking of medications, I was pretty excited after the surgery, though, because I was supposed to be on blood thinners, and
yes,
that's it, right? So that was a win there.
Yes, exactly. Nobody wants to be on blood thinners.
No. And I mean, I didn't really get too hung up on it, because it doesn't. Anything you read about the blood thinners is not. I mean,
no, it's well tolerated.
Yeah, well tolerated. It's more a nuisance. It's just a pill. Like,
yes.
So what are you seeing? Are you seeing an uptick in anything, or what are you seeing coming through the doors? Is there an obesity issue? Is there any trends? What are you seeing?
I would say there's an obesity issue for sure. And, there are new drugs that most of us know about, Ozempic. And all the drugs that are going to be, like, that's tip of the iceberg. So there, that may have a real impact. Certainly not at this
Do you mean
stage.
in a positive way?
I think so, but you know what? It's early days. And I know we have a lot to learn about it. And, it's with any new drug that comes in the market. These are drugs that have been rigorously tested. And there are, no drug comes on the market without very rigorous testing. So they're safe, but we still don't know about the long-term outcomes.
We don't know
So you're talking about a drug that's got a very short experience to this point. Now, it's been around for a while, but we don't know about the long-term effects of it. So, but, it may be encouraging. It seems to be encouraging. So that may address the some of the issue. But that's there's not a dramatic rise in heart disease right now. I mean, I think relative to is in general as a population, we're eating better. There are better medications to take care of cholesterol, for example, and all these things have had an impact in increasing our longevity. Like, we live longer today than we did 10, 20 years ago for sure. So, but we're never going to eradicate heart disease. I'm never going to be out of work, I don't think.
No, you're going to be busy till you join Dr. Matland on the pond, on Golden Pond somewhere. Yeah,
that's right.
Let's get back to some of the other contributors outside, like it's called tobacco. Got to be a bad one. The worst one.
Yeah, that's a real bad one.
That's the worst.
It is.
Right? And drinking?
Not so much. We're talking about cardiovascular disease at this stage. I don't want to say, drinking has no negative
Of course.
For cardiovascular disease, not as much of a big risk factor. Smoking, huge.
Smoking, terrible, yeah.
Right. And so especially for coronary disease, so for a risk of heart attack. And so when I do bypass surgery on a patient who smokes, I say, your long-term outcome is completely dependent on whether you're able to stop smoking. If you can, your outlook's pretty good.
Yeah.
If you can't, it's going to really impact your survival.
We got problems.
Yeah.
Yeah, it seems to me, I feel like it's got to be older people. I feel like the kids don't smoke. Maybe I have no idea. I feel like the younger gen doesn't smoke.
Now.
But then now they vape. So is that bad?
Well,
probably can't be good.
Delivering the nicotine. So the nicotine is really what's damaging the intima of the vessels that is causing the coronary disease. So it's
So nicotine's the bad one versus tobacco?
Well, tobacco contains a nicotine, which now, younger individuals who are vaping are still getting the nicotine. So that's still going to have a negative impact on your cardiovascular health.
There you go.
Taking away the tobacco smoke and the damage that can do to the lungs, maybe that's a bit less, but it's still not good.
Still not good.
Still not good.
So what about guys if they quit smoking and they start chomping on the Nicorette gum? Still bad because you're still getting your nicotine?
Well, yeah. So I guess the idea there is you can wean yourself off nicotine. It's a better way to be able to transition from cigarettes to nicotine gum and then to bring yourself off
and then get off of it.
But yes, if you continue to, it wouldn't be good.
Yeah, we're talking about ways to get people like healthier, and really it should be just quit and don't take, like, because Ozempic was actually a hot topic in our home because my wife sells group benefits.
Yes.
So Ozempic was just everywhere, and now there's another drug coming. I don't know. She hasn't told me the
name. There's a lot coming.
Oh yeah, I would imagine. So it's probably good short-term benefits to help with obesity.
Yes, agree. Yeah. Dramatic, actually.
Dramatic, yeah. Well, interesting. And then after my surgery, I just, what I wanted to say was, this already because we had kind of stayed in touch, but how grateful I was because my mom in Ontario lost my stepdad. She remarried after my father. He's gone now. So she remarried, and then anyway, she lost frank, to congenital heart disease.
Right.
Also, so I was there to witness that, and terrible, awful, and not good for anybody.
Yeah.
Couldn't do anything for him in the end, and very, very sad for her. She still struggles with it, his loss, to be honest.
Right.
But when she came out here to take care of me, along with Dana, my wife, and my sister, she was blown away.
Yeah.
She was truly, both times.
Right.
2 surgeries 5 years apart, actually to the day almost, September. She said, she was literally blown away by the level of care at every level, front to back. And so you guys are like a well-oiled machine in there, it seems.
Yeah, I think we are. And cardiac care, I think, is the example of what we do well in Canadian healthcare.
Mm-hmm.
We don't do everything well, but cardiac care, I think we do. So the acute stuff, and Foothills is high volume, and you do a good job of something if you do a lot of it. And so, we do 1,800 open heart operations every year at the Foothills, which would put us in the top 5% in North America, right?
Right.
It's a lot of volume.
It's a lot of volume.
Yeah, it is kind of like a well-oiled machine, and that's one of the main reasons I think we have as I think the results are reflected in the volumes that we do in a positive way.
So how many surgeons are there? Like how many clones are there of you that are doing what you do? You got a roster?
We do have a roster. We have, there's, we've had a few retirements, and so I've almost lost it. 9 of us, I believe, right now.
So 9 of you handle 1,800 surgeries?
Yeah, we do. Yeah.
Wow.
It's not a lifestyle choice.
Yeah, you're not. Yeah, thanks for popping into here. You're probably in between.
Yeah, no, it's busy. It's a busy life. But,
man, amazing.
But all of us really enjoy our work. And like I said earlier, when we were talking about your first surgeon, Dr. Matland, is that, it's hard to give it up. Right. Because it becomes such a part of your life. And like I said, I feel lucky to be to have such a rewarding job.
Yeah.
To have you here giving this interview, living a normal life, and feel like that's very rewarding to see.
Yeah, it has to be. Yeah, I can just imagine. Well, speaking of that, I didn't want to dive too into it because it's not about me, but I had to. When this whole GND thing started, you were asking me earlier on what's going on with that and what's where. So, for listeners, there's been many pivots in this GND thing. But after my surgery, I really just wanted to give back in some way, and I had this GND company already, which was a drilling company that was failing. And after my surgery, I just realized I got to get out of this thing.
Yeah.
So I wanted to tie kind of energy sector with social services and give back to the Libin Institute was the idea. And that was where you got me this. This was my ECG of my wonky heart before it was repaired. And so we put it on our apparel. And then, here's a picture actually of us. This was in the UFC, the Libin Institute newsletter. And there's all of us together. There you go. My fam. And then there's you. Yeah. So there was just a cool letter. And I it's not like I gave back a ton. I think I gave back like $1,000 in one of the years. Didn't have a ton. I was trying to do something.
Yes, absolutely, and that's what's important. And that's all those contributions, lead to something big. So it's important.
Yeah, it is important. I think so too. I was going to ask you. Oh, what's this one here? Cardio. Oh, sorry.
Yeah, this was just when you guys were talking about different things that you can do to take care of your heart.
Yeah, I thought he had missed something.
Did I say all the right things?
Yeah, you guys were pretty on point with it for sure.
On point. So what's your schedule like?
Yeah, okay, I was talking about the great things about the job. The bad things about the job are the unpredictability. It's tough. It's tough. It's tough on, family, wife, my kids. I don't get to spend as much time with them as I would like. And it's a lot of hours. I mean, if you think of an average 40-hour work week, it's never that.
Never that.
It's often double that.
Yeah.
And it's, somewhere in between most weeks. So
and you've got two children?
2 kids.
Two kids, yeah. How old are they now?
They're 14, 16.
Yeah. Oh, nice.
Yeah. They say they're not going to go into heart surgery.
Yeah, they're not. They want to be like Dad.
Yeah, no, they're who knows what their interests are, and I support them in whatever they want to do.
Yeah,
but, they do recognize that I put a lot of time into my job, but they also see that I enjoy it, so that's the positive.
And you got to be on call a lot. Is that part of your? Yeah.
So since there's 9 of us, it's 1 in 9 call, which isn't too bad. But it's the unpredictability of being on call. Like well, in fact, we've had times when we've been scheduled to meet up and it doesn't happen.
Yeah, I was gonna rip you on it. No, I wasn't. You're
that's the reality. That's tough because
you come when you can.
It's hard to schedule things.
Hard to plan things.
Hard to plan things.
And you mentioned even back then when we were kind of yapping about, hey, maybe you can get out and golf. Do you ever actually get to golf?
Well, in the summer, I try to make that a priority.
Yeah,
I love golf.
Yeah, it's the best.
I try to.
Yeah, I probably don't get to golf much.
Yeah, every year I say I'm turning it around. This year's the year. This
is the year.
I for a lot of years I would get in 10 rounds. That's but I did better. I got doubled that last summer. So.
Oh, good for you. Well, that's better. That's pretty good. We'll get you out.
Oh yeah.
I joined Mickelson last year.
Oh really?
So nice.
Oh, I played it once.
Amazing. It's tough.
To play that again.
But it's amazing. Tough. The first one you always get slaughtered.
Yes, I did.
Yeah, but it keeps you coming.
I did love it though. Yeah.
Yeah, it's a nice course. Well, that brings me to the next thing. I wanted to ask you about your hands because this has got to be your golden ticket. I would think. Yeah. Or am I totally wrong? Like you've got to protect your hands, or do you worry about it?
I think about it a little bit. I mean, it is true, and it wouldn't take too much to take you. Sadly, I've lost. There've been 3 colleagues, 4 maybe, that have had to leave the operating theater because of some physical issue, and prematurely. So, I've had 2 colleagues have to step away in their late 40s, early 50s sort of thing. That's pretty young to be ending your career in the operating room, but it just shows that you really have to take care of yourself and not just your hands, but your overall physical your physical function is important. So you have to. I think you got to stay fit. You got to go to the gym. You got to work on that. I don't want to limit my lifestyle because I'm worried about hurting my hands. I don't do that.
No, but you're cognizant of
a little bit. Some things I try to avoid. I don't mountain bike anymore.
Yeah, you don't do the old knife game.
Definitely don't do that.
Parties. Yeah. No.
Hey, you mind if I ask a question here? So you said something to the effect of 1,800 surgeries in a year.
Yeah.
Split between 9 of you guys, which is roughly 200 apiece.
That's right.
Split between 12 months is 16.6. So you're doing roughly 1 surgery every 2 days.
Yeah. So I would spend, on average 3 days a week in the operating room and 2 operations each day, generally, unless it's a bigger operation, then you just do 1 in a day. But that's right. It works out to about 200 cases, 175 to 200 a year, depending.
And how average time in the operating room is?
Yeah, so for a straightforward operation, maybe 4 hours. I mean, we do 2 operations a day typically. So we'd start in the operating room. I'm there for 7:30 when the anesthesiologist will start. You remember that?
Oh yeah.
Put to sleep and all that.
Bringing back the memories. Yeah.
I start what we call cut skin at around 8:30. So it's sort of an hour to get set up, and then I cut skin at 8:30. In a straightforward operation, I'm trying to be done before noon. So I'm leaving the operating room before noon, maybe between 11 and 12. And then we take a little break, set up the room again for the next one. Probably, depends, an hour and a half. Hopefully, an hour is real good.
Gotta take a break.
Yeah, you have to
gotta eat some lunch or something.
Some power gel India or something.
Yeah. And then we do another one in the in the afternoon. So.
Well, because between my own surgeries, I remember you saying you were happy after the second one because it was like 4 hours or less than 4 hours.
Yeah.
So you were like, yeah, that's
That's good.
Because my first one was over 7 or something. I don't,
Was it?
Yeah, it was 7. It was a long one. Yeah, it went a little longer than you guys expected, I think. Yeah, that is just a crazy life.
Yeah, you don't think about it in the midst of it, though. I mean, it sounds like a long time. If you told me you're going to go in a career where you're going to, stand on your feet at over a
looking
down for anywhere from 4 to 8 to what I've done cases way longer than that too. So, but it goes by. It's intense concentration, and time goes by very quickly.
Oh yeah, I'm sure it does. Well, you know what you're doing. It's going to become routine, I suppose, but you can encounter new issues every time.
Yeah, I don't know that it ever becomes routine.
No,
really. I would say it is. I mean, supported by a great team, and that's the key. And with the support of a great team, I mean, even when it's never routine, you always make it. You get through it, and things go well.
Mm-hmm. Yeah.
But it's a incredibly complex thing, start to finish.
It is complex, yeah. No question. Well, I did want to ask other questions, like, for instance, and maybe not for every listener, like the healing of the chest plate.
Yes.
Was really quite nothing to me. I have often said to people, I had a tibial osteotomy on my right knee, which is straightening a bow. And if I had the choice between open heart or that tibial osteotomy, I would choose the heart. Yeah. It's nuts, but I would, because I couldn't take the pain of the knee.
Yeah, that's true. And it's, that's not the perception people come in to see me with. They think they always say, you're going to crack my chest.
Yep.
And that's
pretty sure I did too. Yeah.
And it does sound terrible. But the reality is, no, the post-op pain is not that bad. And I should also say that I'm such a big proponent of minimally invasive surgery. And but the reality is, a sternotomy, standard open heart surgery, the recovery is not that bad, and the pain is not that bad.
It's not.
It's a great operation. The only thing is, after you do that, there is a period of time where your breastbone has to be stabilized. So you have to be careful with the activities that you're doing. So you
had to go like this.
Right. Yeah. So you can't lift anything heavy. You're not on the golf course for sure. You're not. You're not driving for 6 weeks. All those things. Now that's it's in retrospect, it's not a big deal. But the advantage is we do more and more minimally invasive surgery is that, I'm telling patients no restrictions and activity afterwards. Like you want to go to the golf course, you want to go ahead. Mm-hmm. So that's the difference. But doing it this way, it's a great operation, and that's our standard. And you're right, it's good that people understand that it's not the horrendous pain and cracking of the chest and horrendous experience that you think it might be.
Yeah, you have all these visions or preconceived notions of what,
for sure.
Probably inevitable.
It's true.
But the worst part for me was I couldn't pick up my daughter after. Really, I wanted to pick up my daughter.
Yes.
But pretty small price to pay. I still got to play with her, and she got to hang on me, and she doesn't remember, of course. So luckily, she was young enough.
That's true.
Yeah. Oh, your mic's not on.
If you don't mind, I have a question as well. Can you hear me?
Please.
Yeah, we got you.
Okay. My question is, how many decades so far have you committed to learning, how to be a heart surgeon, and how many more do you see yourself committing as well?
Yeah. That's a good question, because I think about how long it took me to train. It was 20 years of post-secondary education. It's a lot. But it's that's partly my fault. I had a few diversions along the way. I didn't. If you follow a direct course, and I mean, now you can go into med school and go straight into cardiac surgery as a direct entry sort of training. And I didn't. I didn't know that I wanted to be a heart surgeon, so I went into general surgery. That takes a little longer in the extra training, and so I don't. I don't regret any of that. But you can do it shorter than that. I mean.
Yeah, it's a
the
lot
long
of
road.
that's dedication. Yeah.
Yeah. But in retrospect, I loved it. Was exciting. I loved learning. I loved every part of it. It was great parts of my life, even though I was sleep deprived for a lot of years, but it was great.
Well, you look good. You don't look sleep deprived right now. Chipper.
Yeah, I've learned to hide it.
Yeah, that's right.
Yeah.
I wanted to also talk about some of the like the future in heart surgery, and then also the future of the Libin, because there's some things on the horizon there. So some of the guys were telling me there, it was even some anesthesiologists and some of the guys in the room were telling me there was some new tech coming that was pretty amazing. So what is on the horizon in terms of heart surgeries?
Yeah, so it's an exciting time to be in heart surgery because there's a ton of innovation, and most of that is related to being less invasive. So being able to do more not and like we said, like heart surgery is necessary in a lot of cases, but there's a lot more options for dealing with valve disease and with coronary disease, so blockages in the arteries with new stents and interventions that way, but also valve interventions with doing through catheters as opposed to open surgery. So
I was going to bring that one up.
Yeah. And so, we're pretty excited about that. And, Calgary is, I think we're leaders in valve surgery, certainly in Canada and across North America. We want to be world leaders in this, and I think we can. We have a great team. We have a tons of talented people at the Foothills and in the Libin Institute, and supported by AHS and all this. So we got a great.
You got a great team. Oh, you guys are incredible. So so you're talking this transcatheter aortic valve repair and transcatheter mitral valve repair. I was reading about it maybe in the last year or something. You can replace without going in at all, but through a vein. Yeah,
and so this is probably the biggest change I would see. Well, for sure it is in the last 20 years. Well, even shorter. In the last 10 years, dramatic, really.
Yeah.
And transcatheter aortic valve replacement is, it avoids surgery with a procedure with much less trauma to the body, right? So this is done through an artery, access through the groin.
Through the groin, yeah.
And a valve is collapsed down and put through a small catheter into the artery and up to the heart.
There's an image on the screen there, maybe.
Right. And
there you go.
Exactly. And it expands in the diseased valve, sort of like an umbrella opening in a way. The balloon expands.
Yeah, that's what I was picturing. Okay.
So I don't do that particular procedure, but I tell you, there's a real talented group that are doing this. And in many parts of the U.S., that's more common than the surgical valve replacement. And it's, overtaking surgical valve replacement.
Well, that's amazing. And so how long would that surgery be?
Oh, that's very quick. So if we're talking about a standard aortic valve replacement, start to finish, that's a quicker case. We talked about a 4-hour, that'd be like a 2.5-hour case maybe. This would be, less than half that. Yeah. So
wow.
Much quicker. The patient goes home on day one, or day of in some cases. It's an incredible technology for sure.
So then I suppose if I'm thinking of recovery after and comparative to what I had, on that one you'd have your entry, your catheter.
Yeah.
And then I suppose your heart would technically hurt as well.
Yeah.
But
not to a significant pain minimal. Yes, some discomfort, and you have to be careful with the insertion site in the groin, but otherwise, really, no. You're back to, your baseline functional status very quickly.
Well, that is wild.
Yeah, it is. The only issue with it is the experience with it is a little more, it's much more limited than we have with surgical valves. And so, you're trading it's an entirely different procedure. So how is that valve, that very different valve, going to do over 20 years? We don't know as much about that.
Don't know yet.
We know about it over 5 years or a little longer now, but do we know about it 20 years from now?
Not sure.
Not so much.
So probably
we do know what it looks like after a surgical aortic valve replacement after 20 years. We know what's going to happen.
Yeah.
We know the longevity of the valves.
Yeah, so it's essentially trial phase.
Yeah. So this technology is used for older patients.
I was going to say older.
More so.
Mm-hmm.
So for younger, lower risk patients, not so much. Still, it's a surgical approach.
Mm-hmm.
But yeah, it's unbelievable technology.
Oh, that is amazing. And some of these guys had mentioned, and I don't know if that's there or it was like maybe just being tested at the time, but more robotic actually entering your body through robotics. Is that a thing?
Yes, it is. Robotics is it's here to stay for surgery. Its best application is in the belly, not on the beating heart, not on in the heart, but it is used for that. So I think it's well established for urological procedures, gynecology, or abdominal operations, and it has a lot of advantages. It hasn't proven itself in cardiac surgery yet. There's no the robot doesn't have sort of tactile feel. So a lot of what we do is based on our perception of the tissues,
right? And
that is the robot can't do that. So the robot would smash its instrument through this table. Right? So
he's getting in there no matter what.
So there's other ways of sort of understanding the tissue and what's going on. It's not perfect yet, but it's close.
It's
and
coming.
robotics are a lot. There are surgeons that are using it to repair mitral valves. It just takes a lot longer. The advantages versus the disadvantages, takes 2 surgeons to use it for cardiac surgery. Doesn't really work that well with bypass surgery yet. Actually sewing the vessels on the heart, or certain the beating heart and stuff like that. It can be done, and it is done, but not routinely anywhere. And we don't do it yet in Calgary. So there are other generations of robotics that are coming out that I think is going to change that, and I think we are going to be doing a lot of robotic cardiac surgery in the future. But timeline in that is uncertain, I guess.
Unknown. No, it seems inevitable, especially with the growth of AI. We were even just chatting about it earlier here. I mean, it's all inevitable.
Oh yeah, it's exciting.
And also so then the future of Libin Institute itself, I was reading that part of some of that funding, that was the 7.5 million additional from the Libin family, involved in that was specifically targeting to a women's health heart facility potentially.
Yeah, and it's good you're talking about that, because head of the Libin is my colleague Paul Fedak.
Paul Fedak, yeah,
as you know, and he's done tremendous work with that initiative. He's been very supportive of our initiative for minimally invasive surgery. He's really believes in and supports innovation and research, and just the drive and desire to be world-renowned center for cardiac disease, treating cardiovascular disease.
Yeah. And so they touched a bit on it in the article, but why the focus on specifically women's care? So there's a difference.
Yeah, there is a difference, and I think cardiac diseases present differently in women. We've always known this, and the nuances to treating cardiac disease in women. It's recognized now that we should maybe thinking about treatment a little bit different, about diagnosis a little bit different in women versus men. And so, maybe the focus to this point has been to sort of ignore those nuances between men and women. So this is just focusing on these things that we can do to sort of help to treat and diagnose women with cardiovascular disease in a more evidence-based manner than we have in the past.
Get a little more.
It's a great initiative, yeah.
Get a little more precise, more direct.
That's the term, precision medicine.
Precision medicine.
Precision medicine.
There you go, nailing it. Be your intern.
Exactly.
So, but just an example of that, you say they present differently. Do you mean like different symptoms?
Yeah. For example, with heart attack. So if a patient was to develop a blockage of a coronary artery in the midst of a heart attack, a woman does not have the classic center of the chest, pressure, pain, as we're taught to believe. So
Oh.
sometimes, you know, these
Interesting.
things get missed in the emergency department when a woman presents with neck or shoulder pain.
Oh,
You know, so that's an example.
okay. Oh, that makes sense. Wow. Yeah, it's amazing stuff. It's way beyond my pay grade. I know nothing other than was happy to have you fix my heart. That's all I know. Twice.
Twice, yeah.
So, lastly, for yourself, and do you also, you're also teaching as well at the U of C as a prof. How often are you doing that?
Yeah, we're you know, we teach trained residents
Right.
in cardiac surgery. So I spent most of my teaching time would be directed to that. So having residents training to be heart surgeons in the operating room, in the clinic, seeing consults. It's sort of like being an apprentice, right, in a way. And so we spend a lot of time, and we're very proud of our training program here in Calgary. We've trained a lot of surgeons that have gone on to really productive careers, successful careers. So that's a very rewarding part of my job. So teaching med students and at the university, a little bit too. Yeah. So we all give lectures at the medical school as well. So it's
That's good.
it's a great thing.
Teaching the new blood.
Yeah, exactly.
Well, you're a fantastic guy and an even better surgeon, and you're a pillar in the community, and so along with the Libin Institute, obviously, happy to help get you in here and help get the word out and talk about heart health, and keep up the good work.
Well, thank you, Kevin. It's an important topic, so I'm glad that you you experienced it firsthand, of course, but recognizing that it's important to educate people to understand it's good for you. So it's using your voice to educate people is a great thing.
Any way to help, right?
Well, thanks very much.
You betcha. Okay, till next time. I'll see you at my next checkup. I'm due for this year at some point. I don't know what it is.
I'm sure the valve's fine.